Hi, everyone. It's Dr. Kostelnik with Rooted Behavioral Education. I'm a clinical health psychologist and fellow vestibular patient. Today, we have a very special topic, vestibular rehabilitation therapy. And specifically, we're going to be talking about vestibular migraine and 3PD, or persistent postural perceptual dizziness. And today, I'm so excited to welcome Dr. Madison Oak to the interview. She is a doctor of physical therapy who specializes in vestibular rehabilitation therapy, or VRT. She graduated from the University of Wisconsin-Madison and has competency-based certifications in vestibular rehabilitation. She founded the Vertigo Doctor to provide educational resources that are both thorough and understandable for people. So if you want to find her, it's at thevertigodoctor.com, as well as Facebook and Instagram. She has a specific interest in treating vestibular migraine holistically and practices in person and via telehealth, currently in New Jersey and New York State, but she's working on licensure in California, DC, and Wyoming to provide excellent vestibular services for people around the country. So welcome, Madison.
Thank you so much for having me.
Sure. So to get the conversation started, let's talk about what proportion of your patients present with vestibular migraine or 3PD. Is this a big part of your practice?
Yeah, so at my practice where I currently work in New York City, I'd say of all of my patients overall, I do have a couple of orthopedic patients who either started with vestibular dysfunction and then came back to me for a knee problem or whatever. And the rest of them are vestibular. Most people I see are for BPPD, and it's kind of 1 to 3 treatments, and they're usually out after that. And then the other people I have usually are vestibular migraine, vestibular neuritis, or Meniere's disease. Some of them are previously diagnosed, and some people are looking for a diagnosis. As a physical therapist, I cannot provide a official vestibular diagnosis such as vestibular migraine or Meniere's disease or something like that, or PPPD. However, I can sort of help in the education of what vestibular migraine is, and that group of patients within my vestibular patients is probably like 60 to 75%. So it's a decent amount of people that I treat.
Okay, so it sounds like you have a lot of experience with a specific population. So let's talk about when a patient with vestibular migraine or 3PD should be starting treatment. So like, should they be starting when they're very symptomatic? Should they wait until it's maybe medically managed? What is your recommendation for starting VRT?
Yeah, my recommendation on that is that you should be under the care of a neurologist, ENT, or other migraine specialist prior or during VRT. You can come and see a vestibular therapist and say, hey, this is what I'm going through. These are my symptoms. I don't have a neurologist yet, but someone, a friend or family member or something, told me to come to a vestibular therapist, and I'd like to get started. And I don't think there's anything wrong with an evaluation. I think that worst case scenario, your vestibular PT says, okay, you know what? I have all this information about you now. I'm going to save it and use it for the future so we can compare to where you started to where you are now when you come back. So I think that's a good way of going about it. And I also think that you should be relatively medically stable, because what happens is if you're doing VRT and you're doing super, super great, but you're chronically having flare-ups of vestibular migraine or other vestibular disorders, really, then you're going to end up re-triggering the symptoms over and over again. And unless you're treating all of it at once, it's not going to just get better overnight. You can only treat the interictal symptoms of vestibular migraine with vestibular rehab, so the dizziness, the imbalance, and the chronic symptoms, rather than the vestibular migraine itself. So once you treat the root cause, you can do that in a lot of different ways that I think we'll talk about. Then you should get started with VRT, and you can do it kind of simultaneously or afterwards.
Okay. And just to pick out interictal in case people don't know what that means, that's kind of the symptoms you have between the actual migraine attacks. So in VRT, is treatment of vestibular migraine and 3PD largely the same? Like, would you treat those patients with the same exercises or the same recommendations, or are there distinct different things that you might do with them?
So distinct from something like benign paroxysmal positional vertigo, where I would just do an Epley maneuver and hopefully send you on your way if there's nothing else going on. In that regard, yes, absolutely. But vestibular rehab generally is what makes you dizzy and symptomatic, what makes you nauseous, what makes your eyes not feel good, what makes your head not feel good. Push into those symptoms and then relax a little bit. It's the same for Meniere's disease or vestibular neuritis or anything like that. However, what is different is we really need to focus on not triggering a migraine attack. So I never want to make you so stimulated that all of a sudden you're dizzy for 4 days, way worse than you started, and now we've triggered a migraine. And so that would be what I am trying to avoid, whereas other things like exercise wouldn't trigger a Meniere's disease attack or wouldn't trigger vestibular neuritis to happen again, because that can't happen twice. So that is something that I am always trying to balance with all of my patients. Other than that, it is largely similar. I do always try to get people to go to see a cognitive behavioral therapist with this diagnosis, just because there's a lot to manage. And I think stress management is a huge, huge component of VRT. And that's not something I necessarily can provide. Like, I can always talk to you and give you some advice, but I think that a professional in that regard is really, really important.
Okay. I mean, I can speak to that obviously a little bit, and that's, I think we're going to get to this a little bit later in the interview as well. But stress management, anxiety management is a huge piece of the puzzle, because we know that sympathetic arousal, which is part of your nervous system, vestibular symptoms play into that, but so does anxiety or stress. So it can become this kind of big monster. And so you have to break that cycle. And VRT can help break with the dizziness cycle. And then something like cognitive behavioral therapy, or I talk a lot about acceptance and commitment therapy, also can help break that cycle from the anxiety or the stress management perspective. So, and I think you addressed this a little bit, but what are the biggest factors that you see that help people get better and things that prevent them from progressing?
Yeah, so things that prevent people, let's start there, from progressing are not doing your exercises at home. That's like the biggest one that I see. And then not telling me that I'm making you feel worse. That's a huge problem. So if my patients go on, but they don't come back for 2 weeks for some reason, and then they come back in 2 weeks and they're like, oh, I'm like, was way worse for those 2 weeks and you didn't send me an email. Everyone has my email address. And I'm just like, you didn't send me an email and tell me, and I didn't want anything to get worse during that time. It's either better or the same. And so if you're not getting better or you are getting worse and you don't tell me, that's the people who I see who aren't as affected by vestibular rehab. The things that I find are most people who are best with vestibular rehab are the people who identify triggers for themselves. So they log their symptoms. They say, when I watch like this, who track their stress and their hormones a lot. If you're a woman, track your cycle. I think that's great. People who find food triggers, I think that's really important. And sleeping. Sleeping is a huge one. I mean, I think we all know we need to sleep. None of us do it enough. And so if you can stick to the same like 8 hours or 9 hours cycle every night, I find those people do a lot better. There's one more thing that I find.
If you remember, we can come back to it.
Yeah, if I remember, we can come back.
I mean, I was just going to say maybe people who are struggling with the stress management aspect.
Oh, absolutely.
And maybe not even realizing how much that's playing into. Right. And it can be hard. It can be hard to want to go see a therapist. And I think that's one of the major reasons why I wanted to create a course for people, because they can do it from comfort of their home. And I covered the major things we talked about. So like sleep hygiene, stress management, how to use your social support network, neuroplasticity, cognitive health. So I try to hit on the big behavioral health topics.
The big ones that I feel like are the most important that I try to hound people about. But I think someone like you is so much more qualified to be like, here are the ways to change your behavior than I am, obviously. And I think that's so great. Like this course you've made is awesome.
Thank you. Thank you. Okay, so we have a few submitted questions from readers from Instagram. So the first one is, can you explain what nystagmus is and how you evaluate it?
Yes. Okay. So the kind of nystagmus you can be born with is called congenital, and that is not something that I treat. It's something that I can see, and I can say, okay, it's beating one way or the other way. But basically, it's involuntary eye movement. It's named for the fast phase. So it will, let's say, go this way, this way, this way, this way. You can't just, your eye is going to stop at one point. So it has to correct back this way. The slow phase is the correction, the fast phase is the way it's named for. And that nystagmus can be seen for a lot of different reasons. So we can start by the most common reason we see nystagmus, which is BPPV, or benign paroxysmal positional vertigo. And that happens when ear crystals go from where they belong in your utricle and saccule into these three semicircular posterior canals. There's a great article about this on my website if you want to see a visual of this. And so they're not supposed to fall into the canals. The canals are full with fluid, and the two sacs, let's call them, are full with crystals that sit on this kind of jelly stuff. And when you tilt your head forward or you tilt your head up, they move with gravity. There's a linear this way one and a linear up and down one. And if those fall in, they will make your eyes move in an equal and opposite direction of where it thinks your head is moving. These canals are built to detect angular motion. So when you go like this, your eyes move in the opposite way so that you can always move your head and your eyes will stay still. But again, if those crystals are out of place and they go into that canal, your eye is going to continue to move for 15 to 60 seconds until those crystals settle. And then it will happen again when you put your head in a different position. So that's one kind of nystagmus. And that will always be named for the canal that it's in based on the kind of torsion you can see. So that kind, because it is involuntary and it is due to a mechanical problem in your inner ear, that can be pretty simply corrected. That kind of nystagmus, I will observe under goggles. So you can use Frenzel lenses, or you can use Vestibular First is the pair that I use, and they are black out for the patient. They go like this, and I can see them on a screen, and I will look at the direction in which your eye is moving. So there's a couple ways you can do that. And then congenital nystagmus will beat, usually can be direction changing, can be always beating the same way. I've seen it go just down, 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 or up, 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 or to the side one way or the other. And that is from a central dysfunction, and that can be observed both in room light or without light. So if I can only see your eyes, but you can't see. And it just depends on fixation or lack of fixation. So fixation being I can stare at my thumb and the nystagmus will stop, versus if I'm just kind of like this and I'm not staring at anything, then nystagmus might come back. So that's that's my long-winded way of saying how you can observe or find nystagmus and what it is.
Okay.
Again, involuntary eye movement.
Okay. So it sounds like it's either central or peripheral. Peripheral would be the crystal. Central would be the more of like a brain problem. And you said it's congenital. Okay. So
it doesn't have to be congenital if it's central.
Okay.
Like you can get this nystagmus with the vestibular migraine.
Okay.
And so you can pick it up on a VNG, or I sometimes can pick it up in clinic just with those goggles on, and it won't always be beating the same way necessarily.
Okay. Okay.
So just make a note of it.
Yeah. Okay. The next question is, and this is, I know, a monster to answer, but what is the cause of vestibular migraine?
Okay. So this one, I'm going to hand over to Dr. Shinbei's book, and I'm going to kind of explain it to you the best way I know how, which is how he explains it. So I went back last night and I like really reread exactly how he explains it, because he, in my experience, is the best person to explain this. So the book Victory Over Vestibular Migraine, if you haven't read it, is something that I would recommend to basically every vestibular patient, but especially vestibular migraine and 3PD patients. So migraine itself is a trigeminal nerve problem. The trigeminal nerve is a nerve that is a cranial nerve. So it comes out of your brain and goes directly to its innervation versus coming out of your spinal cord, which most nerves do. You have multiple cranial nerves. Trigeminal nerve is your fifth one, and it goes from your brain and it goes here, here, and here. It kind of goes out in this three-pronged fashion. It controls sensation of your face, head, meninges, which is the covering of your brain, and then the surfaces of your blood vessels of the skull. So migraine happens when you have something called a cortical spreading depression, or a CSD, which is an electrical hypersensitivity signal that occurs across the brain, and then it's followed by a depression activity. This causes activation of the trigeminal system, and it leads to parts of the meninges, the dura specifically within those layers. One of your meningeal layers is your dura, and the upper cervical cord. Some stuff in there just changes. It also causes neurogenic inflammation, which leads to a release of more inflammation chemicals. So it's a feed forward response. So the more chemicals your brain sees, the more they make. So it's sort of like an over and over and over problem. This dilates blood vessels and stimulates immune cells, irritates sensitive nerves. And this response will continue to drive the migraine response. So you have many systems that are affected here. And for some reason, in some people, the vestibular system is also affected. So you have your vestibulocochlear nerve, which is in charge of your hearing and balance. It goes from your peripheral vestibular system to your brain. It's cranial nerve 8. So it's the same situation as your trigeminal nerve. It's also cranial nerve. So the abnormal neuronal signals that are being sent during that CSD, because the trigeminal and vestibular cochlear nerve do have a connection. Basically what happens is these nerves are linked. And for some people, obviously not all people with migraine, but some people with migraine also get the dizziness and vertigo response. So that is what characterizes vestibular migraine. Not all dizziness during migraine is vestibular migraine. There is a very specific classification and diagnostic criteria for vestibular migraine. You can have dizziness and also have migraine, but it doesn't mean you have vestibular migraine.
Got it. Okay, cool. Thank you for explaining.
Oh,
yeah, no, that was very technical and
very technical.
Still wrapping my head around it a little bit.
Basically, so in, I think, simpler terms, we could say that you have the migraine response from the trigeminal nerve, which is most migraine or all migraine. And for some reason, because your trigeminal nerve and your vestibular cochlear nerve are so close, some people also get vestibular symptoms.
Okay. And then the last reader question was, is it possible to heal from vestibular migraine without medication?
So yes and no. It is possible. People do it. But I do think that I am not a physician. I'm not providing like pharmaceutical advice here, but what I see in the clinic is that people who even start with a pharmaceutical prior to trying to wean off and doing it all holistically have an easier time. So not all people need pharmaceuticals forever. It's not something you have to take a prophylactic or preventative medication forever, but there are those 3 classifications of vestibular prescriptions. So you have, or migraine prescription, sorry. So you have the preventative or prophylactic, then you have a rescue medication, and then you have an abortive medication if the rescue medication doesn't work, or maybe it's the other way around. Regardless, those are 3 classifications of them. And so not all people need a prophylactic. Some people are like, oh, I get really stressed out, and then if I drink caffeine, those 2 things trigger a vestibular migraine for me. So if I just avoid that, I don't need this prophylactic. But for some people, their migraine brain is so sensitive that they're like, okay, I need this prophylactic to help. And then if something happens, then I'm also going to take a triptan or whatever that is for you. Some people need caffeine for their migraines, and it's completely different. But I find that people who start with medication and then slowly wean off and maybe still have a rescue or an abortive medication will really do well if you are looking to just have no medication at some point. But you do need to really control your triggers, whether it's stress and anxiety, whether it's sleep, caffeine, food. Exercise is a big one. I think that's the one I missed from the beginning. People who exercise at least 30 to 40 minutes a day do so much better than people who do not. And so it's just all those things combined. So yes, it's possible. It might be a little bit harder and a lot more lifestyle changes. So it's sort of what you're willing to balance in your own life.
Okay. Thank you for answering that. I think that concludes all the questions. Was there anything else that you wanted to add?
I don't think so. Yeah, that was great.
Okay. Well, thank you to Dr. Madison Oak so much for being on the interview today. Again, you can find her at the vertigodoctor.com on Facebook and on Instagram. And again, I'm Dr. Kostelnik. You can find me at rootedbehavioraleducation.com, also on Instagram and Facebook. I'm trying to post educational content pretty frequently. So if you're interested in being notified of new content, you can subscribe or comment. I'd be happy to meet you, and we'll see you next time.